While technological advancements such as electronic health records and telemedicine offer potential benefits, their integration into the healthcare system has been challenging. I speak with Dr. Kate Tulenko as she outlines what the future of healthcare will look like.
I took quite a number of anthropology.
I met Tulenko in our offices in Washington, D.C.
And the British have recruited away all their nurses.
Kate, always great to see you. Talk to us about some of the structural challenges facing the U.S. healthcare system.
Well, first of all, it's important to understand that the U.S. healthcare system is extremely complex. It's the single largest sector in the U.S. economy. It's 17% of the U.S. economy, over $4.8 trillion, and it's the largest employer in the U.S. And there are a number of major problems. It's not a silver bullet with the U.S. health system. For example, there's about 3 million uninsured people in the U.S., and the people who are uninsured are more likely to be poor and more likely to be sick, so that compounds the problem. And also, we have a very fragmented healthcare system. They don't share data, things aren't interoperable, the public health system doesn't talk to the private care system. We also incentivize sick care rather than preventive care. That's another challenge. We have a huge health workforce shortage and maldistribution. The federal government tracks about 7,000 health professional shortage areas. About 3 in 5 are in rural areas, and the majority of them are in red states as opposed to blue states. And then also, U.S. citizens pay more for their medications than people in Europe do. And that's because Congress forbids Medicare and Medicaid to negotiate the cost of drugs, even though many of these drugs are actually developed in the U.S. with public funding, such as NIH funding. Now, Biden had rolled that back and allowed Medicare and Medicaid to negotiate on a few key high-expense drugs, such as insulin, but that's been ended now, unfortunately. And then lastly is our agricultural policy. The incentives to American farmers is to produce commodities such as corn and soybean, which are very high-calorie dense, and go into processed foods rather than incentivizing fruits, vegetables, unprocessed foods.
When I think about what you just said, the lack of insurance, the lack of healthcare providers, red states, I think of like Appalachia or something like that, where all of that converges. How does that impact patient care?
Well, it makes it much worse when there are health worker shortages, when people don't have health insurance to pay for a visit, they delay care or they don't get care at all. So when they do show up, it's more expensive to care for them. They're more likely to die. In fact, rural Americans die about 2 to 3 years earlier than urban Americans. And so it has a huge cost that way.
And in terms of healthcare and how much money is spent per capita, I mean, the U.S. is right up there, and yet it seems like people are not really satisfied with the care that they give. Can you talk about that disparity? I mean, where's the disconnect?
Well, it's in 2 ways. One, it's the unnecessary care that's given because health providers are incentivized to give care that I'm paid if you're sick and I take care of you. I'm not paid if you're healthy. So that's one thing. And 2, because so much care is delayed, it's very expensive when people finally show up. There's prevention, and then there's also, we call primary prevention and secondary prevention. So primary prevention would be to prevent you from getting obese, prevent you from getting diabetes. Secondary prevention is once you have diabetes, once you have high blood pressure, to prevent it from causing a harm to you. And we need to focus on those types of prevention rather than the treatment of the end organ damage, the end damage that these diseases do. Another reason why it's so expensive is we have private for-profit health insurance in the U.S. And in some ways, it's a form of profiteering. When you compare the U.S. system to Europe, they either have public systems or they have small nonprofit systems, such as Germany has their sickness funds, Switzerland has equivalent funds. If we had Medicare for all or the Swiss system, we would save literally $25 billion because that's the size of the U.S. health insurance industry with about 1,000 health insurance companies in the U.S.
But you hear the arguments, like, oh, the U.S., the system's so much better than these other places. You have to wait for care and all of that sort of thing. What do you think when you hear these arguments that, oh, no, the system's, there's not a problem with this?
Well, it depends on who you are. If you're someone with health insurance and you're someone who's very savvy, it can be excellent. But if you're someone without health insurance, or you're someone who has health insurance but can't access it because it's 2 hours away, over half the counties in the U.S. don't have a single OBGYN. So pregnant women have to drive for hours to reach care. So it really depends. We have, in a way, two systems. We have one system for people with health insurance who are very savvy, and then we have another system for all the rest.
Dr. Tulenko is the CEO of the Center for Health Professional Schools, which is collaborating with partners worldwide to train an additional 1 million health workers over the next 10 years. You talked about the rising costs of healthcare. When we talk about healthcare, we think about remedies. Are there remedies for the system itself? And how easy would it be to adapt to some of these remedies?
Absolutely. For each of the problems I described, there are fixes. For example, the lack of health insurance. We can have Medicaid for all, or we can use the sickness funds, such as they have in Germany. For the high cost of medications, we can go back to Biden's plan of allowing Medicare and Medicaid to negotiate drug prices so that Americans pay the same amount as Europeans do. For the issue of the health worker shortage, we can train more health workers. It's a myth that nobody wants to be a health worker in the U.S. Every year, nursing schools and medical schools in the U.S. turn away tens of thousands of qualified applicants. So we need to expand these schools, and that's by investing more. Also work with the regulators to be less rigid. Many of the regulators don't allow the distance education. That's starting to change. For example, Arizona State University, one of their nursing schools, the first 2 years are completely online, and then the second 2 clinical years are in person. So we can do things like that to make it more affordable to train an adequate number of health workers. We also need to better leverage technology, AI to do remote monitoring of seniors either in their own homes or in group facilities, and that can be monitored either by health workers domestically or health workers in the global south.
It's interesting. I went to APEC in Peru, and one of the people who got up and talked about the issues facing the member countries was aging. I mean, it's not just a U.S. problem. Is this something that people are starting to focus more on? Because it really is going to be kind of a huge issue moving forward, isn't it?
Yes, I think countries have finally woken up about it. For a long time, there was denial. People would say, we're good Christians, we're good Muslims, we're good Kenyans, we take care of our elders. But, there are fewer children. Adult children are in the big cities. The elders are in the rural areas, or adult children are out of the country. There's more divorce. Women are working. So there's just not the traditional family system to take care of people anymore, to take care of elders. And plus, the care needed by elders is much more sophisticated. And so often the family can't provide it. So you are starting to see governments all over the world start to come up with elder care strategies.
Stepping back to the healthcare field, I have a friend of mine who's a doctor who he started a practice, added 3 other doctors to the practice. They're kind of humming along. Everything's going fine. One day, the other partners asked to have breakfast with him, and they said, look, you spend too much time with the patients. We got to cut this back. We got to do this and that. And we want you to leave the practice, because he was old school and he wanted to spend a lot of time. That's another problem within the healthcare industry. In order to make the money that these people want to make, what you do with the patient is limited, isn't it? I mean, it's kind of cockeyed.
There have been 2 large factors affecting that. One is the introduction of the electronic medical record. Your physician probably spends more time looking at the computer screen than looking at you. So when EMRs were introduced, they didn't redesign the workflow. The product you get in, the record with an electronic medical record is very different from the scribble that used to happen with the paper. And they should have recognized that getting a different product, you would need a different workflow, and that they probably either needed to introduce scribes, whether, humans or AI scribes, or give people longer to take care of their patients. And that's one of the issues. And the other issue is that Medicare has been reducing physicians' rates. So in this time of inflation, food prices going up, physicians actually make less, per patient, per procedure. And that is just unacceptable, especially since, costs are going up so high so quickly.
The cost of healthcare in the U.S. continues to outpace inflation, making it increasingly unaffordable for many Americans. High costs are driven by factors like expensive medical technologies, administrative overhead, and prescription drug prices.
You mentioned diabetes and kind of getting there on the front end rather than the back end, the savings and costs. But the system is not designed to do preventative care. How do we kind of change that model, or is it possible?
Well, I think it's going more towards the public health and the preventive. For example, allowing you to making gym memberships tax deductible. Making healthy food more affordable. There is an insurer in South Africa that pays people to buy and eat healthy food as opposed to processed food. And they actually have been able to show it makes a difference in the health of their members.
We talked about the shortage of healthcare providers. Is there a solution there as well? I mean, how do you get more people interested in this field, given the fact that we just talked about you're not going to get paid like you used to back in the good old days? There's a lot more paperwork involved. There's a lot of issues involved.
Well, definitely people are interested. And, when you look at surveys of the professions that are most respected in the U.S., nurse and physician are always high up there. People want to be healthcare workers. We just have to expand the training. And it's very frustrating because the U.S. has so many people with bachelors who can't get a job. And we, at the same time, we're not training enough healthcare workers. We have to do what South Carolina does, and they align public tertiary education funding with open jobs in the states. So if there are no open jobs for ancient Greek speakers, they don't fund the ancient Greek department as much. But if they have 5,000 open nursing positions in the state, they put much more money to the nursing schools to train more nurses. And so we have to align the funding for higher education with the needs.
Talking about nurses, we interviewed a nurse who was very active during COVID, and what she witnessed was just mind-boggling and difficult and traumatic. And in many cases, these people took their last breath. That was the last person they saw. And you think about people in that field and just how tough it is, and maybe I want to transition into something else. Did we see a fallout as a result of COVID in terms of healthcare providers?
Oh, absolutely. Studies globally have showed that about 1/3 of healthcare workers everywhere have either anxiety, post-traumatic stress disorder, or depression. Most of it stemming from what happened during COVID. And the overwork makes it worse. So it's a vicious cycle. You might remember last year when 75,000 Kaiser healthcare workers struck, one of their main negotiation asks was for Kaiser to hire more healthcare workers to take the burden off of them. Because once again, it's a vicious cycle. If I'm taking care of 10 patients rather than the 5, which is standard, I'm going to get more burned out and be more likely to leave, which means there are even fewer healthcare workers to take care of the same number of patients.
And then the stigma attached with trauma, like, do you really want to go to your office and say, look, I've got burnout, I'm really traumatized? There's a stigma associated even within the healthcare community.
Well, you can lose your license, for saying that you have a mental health problem, and there definitely needs to be reform in how that happens. There are really some horror stories, especially of physicians losing their license due to mental health diagnoses.
Despite the Affordable Care Act, millions of Americans remain uninsured or underinsured, limiting their access to essential medical services. Geographic disparities persist, with rural areas often lacking sufficient healthcare providers.
Kate, I've had the good fortune to interview you several times. I can tell you're passionate about this field. What is it that drove you to get into it?
Oh my goodness, healthcare. Well, it's because when I was in college, I wanted to find something that combined my love of science with my love of anthropology and understanding people. And that's how I came upon healthcare.
And so what have you learned about people through this process?
A lot. I mean, culture and the social determinants of health really do determine people's health. That, in fact, it's much more important than the actual type of health care you receive. Your behaviors, if you drink, if you take drugs, how much you exercise, what you eat, and all those are very culturally prescribed, those have a much larger impact on your health than the healthcare that you receive.
The prevalence of chronic diseases like diabetes, heart disease, and obesity is rising, placing a significant burden on the healthcare system. Effective management and prevention strategies are essential to reducing the long-term impact of these conditions.
I spent a lot of time in China last year, and the future is now. AI, robotics, you name it, and you think about all of that being introduced into the medical profession moving forward. It's going to be a brave new world in a sense. How do you see it unfolding?
Yeah. Well, right now the main challenge is legal liability because it is the healthcare worker's license that is on the line. And so there's a reluctance until we have the tort reform that settles that healthcare workers are going to be reluctant to use AI. But I think once we get that settled, we'll have a renaissance of being able to take care of more patients more efficiently and with higher quality of care.
I think we touched on this briefly. You talked about kind of these two pools. One, the people who really know how the system works, they use it to their advantage. The other kind of left over here, they don't really have health care, insurance, and that sort of thing. How do we make it more equitable?
Well, part of that is making sure that we have health workers in every community. In addition to, I mentioned that people are less likely to be diagnosed or had delayed diagnosis if they don't have access to a health worker. Also, there's that lack of establishment of trust. If you see the same physician, over 10, 15 years, you're going to trust them. But if you, only are able to see a physician once, or if it's a different physician each time because they're rotating people in due to the shortage, you're not going to have that level of trust. But if we have community health workers, or if we have physicians and nurses based in rural communities for long periods of time, they will build up that trust, and that we'll be able to address, the misinformation and the mistrust, and just the, the pandemic of vaccine hesitancy and misinformation that we have.
Yeah, there's the Hollywood version of things, and then there's the real version of things. You know a lot about the real version, but the Hollywood version is the doctor runs in, he comes up with some great idea, does this bypass surgery or whatever, saves your life, and in a half hour, everything's strung together and it's perfect. The real world's much different than that. How do you see the healthcare system, kind of the trajectory over the next 5-10 years? Where do you see it going? Where would you like to see it going?
Well, I think that a lot more of the responsibility is going to be shifted to the patient to do more self-care, and to do that preventive care. And I think we are definitely going to get more into the personalized medicine where your genome will be sequenced and where certain risks will know your exact risk for dementia, for heart disease, for high blood pressure, and we'll be able to prescribe not only medications, but a lifestyle for you that will prevent you from getting those conditions.
Let me ask you one final question, which is, you were talking about the lack of healthcare providers out there. One of the things that I've seen in recent years, at least in Northern Virginia where I live, doctors just don't want to treat the patients that they've had with their health insurance. They want concierge, where you have to pay extra money and you'll get to call them and you can actually go see him. Again, you've got these tiers that you talked about, the one tier and the other tier. It's almost as though they're creating a third tier. People who've got a lot of extra cash who can get kind of the treatments they want. Can you talk about that disparity? And are we going to see more of that, do you think, moving forward?
Well, that problem is basically due to the private health insurance because the private health insurance makes it much more difficult. There are some companies that automatically deny coverage without even looking at the case. And physicians have to call and argue for their patient. They're not compensated for this. Some physicians say that, they have to have like one, a data collector and biller for every physician because the bureaucracy due to the private health insurance is so much. And that's why physicians are moving to this concierge medicine. And yes, it will create even more inequity in our society, especially we've already outpriced our ability to give everyone the type of care that we have. I mean, we can grow artificial livers. We can give people, bone marrow transplants. We're not going to be able to afford to do that for everyone who needs it. And that inequity is just going to increase.
So knowing what you know, how hopeful are you about the future?
Well, I mean, I think in the U.S., it depends on, what the public decides to do. And if the public says that they feel every American has a right to health care, then it will change. But if we continue on our current course, then we'll have even more inequity, unfortunately.
Kate, always a pleasure talking. Thank you.
Thank you so much.